It's 8 a.m. and I want to welcome everyone to day 5 of the Bloodless Medicine and Surgery Week 2025. My name is Adrienne Korzeniewski. I am a nurse with the Bloodless Care Services at ProMedica Health System in Toledo, Ohio. And today is a very special day. It's World Bloodless Surgery Day. On May 16th in 1962, Dr. Denton Cooley successfully performed the first bloodless open heart surgery. And this day is dedicated to raising awareness, sharing research, and celebrating the medical professionals who pioneered bloodless techniques with dedication and excellence. And the theme for today is Patient's Blood, the Best Blood. And I'd also like to introduce my co-moderator today, Dr. Bruce Spies, Emeritus Professor of Anesthesiology in the University of Florida, USA, and he is a member of the BMS, the Bloodless Medicine and Surgery Society, as well as SABM.
Thank you, and thank you, Adrienne, and good morning to everybody as well. Today, there's a few little housekeeping items to say. Please, everybody, keep the chat to sort of questions and answers rather than just spending a lot of time with chatting backwards and forwards about, that was a great point or this lecture is fantastic. We want to try to keep everybody focused on the lecture. It is indeed honoring bloodless surgery and Denton Cooley, but we're also going to, in our second lecture, we're going to honor and begin honoring some people who have been foundations for bloodless medicine and for PBM. I'm one who strongly believes that PBM has evolved, but that bloodless medicine is the ultimate evolution of where we're going. And I think I'll leave it at that until we get going through these wonderful two discussions. Thanks, Adrienne. I'll turn it back to you.
Well, thank you. So our let's see, our first lecture for the day is Dr. Neil Bloomberg. He is the director of Transfusion Medicine Division and Blood Bank of an 880-bed hospital, university hospital, and professor of pathology and laboratory medicine at University of Rochester, New York, USA. He received his BS and MD from Yale University in New Haven, Connecticut, and had his residency training in laboratory medicine, hematology, and blood banking at Yale New Haven Hospital. Dr. Bloomberg's particular interest is in transfusion immunology, having participated in research into the previously unappreciated immunologic effects known as transfusion immunomodulation. His clinical interests are in the diagnosis and treatment of immune disorders such as autoimmune hemolytic anemia, autoimmune thrombocytopenia, supportive care for stem cell and solid organ transplantation, and mitigating transfusion side effects through leukoreduction, use of autologous transfusions, and removal of stored supernatant through washing. His group, co-led by Dr. Joanna M. Heal, MRCP, described the ill effects of transfusing ABO-incompatible soluble antigen and antibody. Dr. Bloomberg is a member of several professional societies, including the Bloodless Medicine and Surgical Society and the Society for the Advancement of Patient Blood Management. And he is in the Hall of Fame of the Association for the Advancement of Blood and Biotherapies. Dr. Bloomberg's theme today is Patient's Blood, the Best Blood, and we'll turn it over to him.
Thank you for that kind introduction. Let's see if I can manage to share my slides here. There we go. Okay. Can everybody see that? Okay, so today, among other things, we are honoring Denton Cooley, who, as was mentioned, was an extraordinary surgeon who accomplished many things in his career, but one of the things he did accomplish was introducing the concept long before it really had a name of bloodless medicine and surgery, particularly cardiac surgery, which is his specialty. And this is a very brief summary of that aspect of it. He had a long and productive life, uh, mostly operating in Houston, Texas. Uh, but he was the first really to undertake the care of witness patients who did not want to receive transfusions. And as I think all of you know, um, transfusion has been the default, uh, as Dr. Spees mentioned, for treatment of anemia or bleeding of any sort. And in fact, through indication creep, has become a way of adjusting the hematocrit and hemoglobin through numbers rather than addressing clinical problems, which is a major issue because, uh, as shown in this slide, which was put together by a number of pediatric intensivists who published on the subject, transfusions dramatically alter in the way transplant does the recipient's immunity. And unfortunately, this is mostly, not entirely, but mostly uh, uh, for the worse. The particular problems that Paul Tarter and many other people working in this field, including our own group, have delineated is postoperative infection in surgical patients. But it also has similar sort of immunosuppressive, immunomodulatory effects in medical patients. And this is true whether you're a pediatric adult or whatever. I'm not going to go into this, just sort of the literature is readily accessible for those of you who want to read about it in detail. But it raised the question as to whether transfusion was an appropriate intervention for dealing with many clinical problems. And in fact, the evidence is that transfusion makes things worse rather than better. And that's obviously not the goal of any healthcare professional. So, what are some of the evidence that we can mitigate these things? Well, obviously, if you don't transfuse patients, you don't have these effects. But transfusions are still widely used, and while patient blood management is not primarily about preventing transfusion, that's one of its most important derivatives. And as Dr. Spees mentioned, for obviously for those who are practicing in the bloodless setting, either because of patient desire or professional opinion, it's not an issue. And I will address some of those things in this talk, and I'm going to be covering some of the ground that's been covered by other speakers this week, such as individual strategies that appear to improve clinical outcomes for patients, reduced infections, improved survival, all the important endpoints, and obviously reducing suffering. But I will also, near the end of the talk, address how an integrated, comprehensive program of either bloodless or patient blood management approaches to patients have integrated a wide variety of strategies that, taken together, make an enormous impact on many issues. And because I think that's in many ways what this society and SABM and similar groups are interested in, which is reducing suffering, improving clinical outcomes, and unusually in medicine, actually saving money. It's very rare that medical advances do that. So this is a study that came from Barcelona and was in patients with GI bleeding and showed that when you try to use a more conservative or restrictive strategy for red cell transfusion, it actually improves survival in a randomized trial. And this, I think, has uh, made a great impression on a lot of people. There are a variety of other similar studies, um, but I think hasn't really quite entered the consciousness of the medical profession as a whole. Um, I still find many of my colleagues transfusing based on hemoglobin rather than clinical indications, and not being terribly concerned about the fact that transfusion may impair their patients' chances for a happy outcome. So, if you looked at a bunch of other randomized trials that have done, and since our topic this week is orthopedic and trauma surgery, these are studies in orthopedic surgery. And this is a bit of a complex slide, but for those of you not familiar with meta-analyses, the thing to look at is this triangle right over here. This is a way of summarizing multiple studies and mathematically, and it's particularly valuable for randomized trials. And you can see that, in fact, uh, this graph shows whether the outcome favors restrictive transfusion or liberal red cell transfusion in orthopedic surgery. And as you can see, nosocomial infection, meaning hospital-acquired infection, postoperative infection, is reduced by approximately 28% in these randomized trials when a restrictive strategy is used. So that's a very important thing to understand, and is, of course, proof of the fact that transfusions are altering patients' outcomes, and that if we use less of them, if we find ways of using less of them, we have better outcomes. And it turns out that there are at least three strategies that will do this. And back 35 years or so ago, our group became interested in this immunologic effect of transfusion, and we hypothesized that autologous transfusions, in this case pre-deposit, where a patient donates blood before surgery, that these would have better outcomes than patients who got allogeneic red cells. They were not randomized trials, but they were really quite striking findings. One in hip replacement, which obviously in orthopedic surgery, and the other in knee replacement, a spine surgery rather, not knee replacement. And as you can see, the fever and infection was dramatically improved when patients only got their own blood back. And this was objectively shown through days of postoperative antibiotics, length of stay, and that the results were quite striking. And so a series of randomized trials were done by multiple other groups in mostly vascular or orthopedic surgery. And these were various autologous techniques that were used, including intraoperative salvage and or normal volemic hemodilution, as well as pre-deposit uh, um, autologous transfusion. And these are randomized trials. And so this is a summary that shows that nosocomial infection, meaning infection after operation, was cut in half in patients who used autologous techniques. Now, I realize not all patients accept all of these techniques, and there are a lot of factors involved. It turns out that probably the best thing for the patient is things that anesthesiologists and surgeons and perfusionists can do, such as cell salvage or normal hemodilution, since the patient is actually anesthetized during that procedure as opposed to pre-deposit, which is a bit inconvenient. And unfortunately, in the blood transfusion community, autologous transfusion has become very unpopular. It's a lot of work. Uh, Blood bankers do not believe that transfusions cause immunologic effects on patients, as it turns out, despite 40 years of research. And so autotransfusion that are done through transfusion medicine services has pretty much vanished in the United States, but it's still being practiced to some extent by anesthesiologists and intensivists and perfusionists and surgeons through cell salvage or normal volemic hemodilution. And these are all pretty much equivalent and good for patients and good for possible costs in society. And one of the most impressive studies was a randomized trial done by Marcus Heiss, a surgeon in Germany, published a long, long time ago. They used autologous transfusion through pre-deposit. And as you can see here, those who were transfused 1 to 2 units, the infection rate was literally 1/3 or 1/4 uh, in the patients who got autologous transfusion. This was colorectal surgery, and it turns out not only were there fewer infections, but there were fewer tumor recurrences in the patients who got autologous blood. And this graph shows their randomized trial published over 30 years ago in the Journal of Clinical Oncology. And interestingly, they also correlated this in similar groups with improved immune function. This is something called delayed type hypersensitivity, which is a skin reaction to various antigens, usually microbial antigens. And you can see that the patients with autologous blood actually had an increase in immune function, whereas those who got no transfusion but surgery alone had a slight decrease. Those who got allogeneic blood had an even even bigger decrease. And so Dr. Heiss and his group really, I think, demonstrated conclusively that both clinical outcomes and immune function were impaired by allogeneic transfusion and to some degree by surgery and anesthesia itself, but that autologous transfusion actually improved immune function and improved clinical outcomes. So that's very important from a mechanism standpoint and for proof of principle standpoint. So the rest of my slides I've borrowed from Dr. Axel Hoffman, who many of you know as one of the leaders in the field of patient blood management. And he and Erwin Gross and a group of physicians and other nurses and investigators have recently contributed to the WHO, World Health Organization, document on patient blood management, which was just issued. So what are we treating here in bloodless medicine and surgery? Well, we're either dealing with bleeding or anemia. Those are the two things that are obviously major issues in these patients. And it turns out that, in fact, iron deficiency anemia is the world's most common disease. And it's often not even anemia, but iron deficiency causes cognitive problems, immune deficiency, and many other issues that are only now being elucidated. We're talking about billions of individuals. And these slides will be available, obviously, on YouTube and in the permanent version of this talk. So you'll be able to look at the references there if you want. So iron deficiency, anemia is very common, and iron deficiency is by far the most common cause. As a laboratory-based hematologist, and we often are worrying about important clinical syndromes like sickle cell anemia and thalassemia and various enzyme deficiencies, infectious diseases, but it's really iron deficiency. And obviously, this is particularly a problem among female patients. So we've known for some time that anemia increases bad things that happen in medical care, including stroke, infections, operative mortality. Now, we don't know to what extent this is anemia and to what extent this is transfusion. They probably both play a role, but these are serious increases in the odds of a bad outcome, 2- and 3-fold differences. And in fact, the problem here is that while anemia is a problem, you can see that the increased incidence of hospital mortality is 4-fold in anemic patients. It's not fixed by transfusion, which is in fact, standard approach in most places in the world. If you're not in the bloodless medicine and surgery program and you don't have patient blood management, which is true in most of the hospitals in the United States, the mortality rate is also 4-fold higher approximately in transfused patients who are anemic, and transfused patients who are not anemic have the same sort of mortality as patients who are anemic don't receive transfusion. So transfusion does not fix the problem. So one of the strategies that has been very successful in some settings, although this is controversial in some quarters in the medical profession, is intravenous iron, because it's obviously a pretty good treatment for iron deficiency anemia, and it works pretty quickly in the matter of days to a week. So it can be used in patients who are going to have surgery fairly soon, and even in patients who are about to go to surgery. And there are, in fact, a lot of preparations that now can be used. That's not my area of expertise. But in this particular study, Dr. Fersler and colleagues published in the Annals of Surgery, they compared in a randomized trial IV iron in anemic patients with iron deficiency, and they wound up having to terminate the study for a variety of reasons. But other studies have appeared over the years in anemic patients. Same drug here. They also received erythropoietin, the growth factor for erythropoiesis, red cell production. And they also received uh, subcutaneous vitamin B12 and oral folic acid. So they pretty much had the growth factor covered there in this study. Um, and what they found is obviously, or maybe not so obviously, they had a dramatic increase in hemoglobin concentration and iron stores, and they reduced transfusion by sixfold. And they also reduced perioperative infections by sevenfold, and length of stay was reduced. So these are all terrific outcomes for a relatively modest investment with a very safe series of therapies. And this is some further data from these studies, an eightfold increase in hemoglobin prior to surgery, um, just really terrific results. One other approach that has been used, and I think many orthopedic surgeons, of which I am not one, have taken up, is antifibrinolytics to reduce the amount of bleeding in the surgical setting. Tranexamic acid is perhaps the most commonly used. It's very simple, it's very cheap, inexpensive, it's very safe. Epsilon aminocaproic acid, it tends to be a hematologist favorite, but has not been used as much in surgical studies. But in fact, in terms of outcomes and however you measure either safety or efficacy, tranexamic acid, which costs literally pennies, a few dollars, dramatically improves outcomes in general surgery and other types of surgical interventions. And there's, of course, a big body of data in trauma, use of tranexamic acid in that setting, and also in perinatal bleeding. So both orthopedic surgery and trauma, the subject of this week's emphasis, are benefited through the use of these antifibrinolytics. The other thing that's been used extensively, and Dr. Spies is one of the world's experts, so I'm not going to go into great detail here, but the use of viscoelastic tests. These are coagulation tests for those of you not familiar with, like thromboelastography or rotational thromboelastometry or Hemasonics Quantra. These are comprehensive whole blood coagulation tests that are now being used in many settings to drive therapy, whether it be DDAVP, tranexamic acid, or in fact transfusion, that these lead to better outcomes, both in terms of mortality, reduces transfusion. You can see here's the mortality rate, it's decreased substantially. And the same thing's true of transfusion. So one of the uh, interesting things about patient blood management is as it has become a comprehensive approach, it has improved dramatically. Now, this is back in almost 20 years ago in 2007. There were three pillars of patient blood management. Now we have four, and we have more tools. But these are still remain major important parts of the patient blood management approach, and also a part of bloodless medicine and surgery, obviously, which is the surgeon reducing surgical blood loss, the anesthesiologist using sometimes selective hypotension, acceptance of lower hemoglobin levels, and obviously optimizing red cell mass. Obviously, also, trying to maximize normal hemostasis in patients who may be taking anti-platelet drugs or anti-clotting drugs. So, in this study from Donat Spahn in Europe, they had two periods of time, one which was used a more comprehensive patient blood management, patient blood management approach versus traditional management, and this is shown in detail on the right here. They had these are some of the things they used, some of which would be considered still appropriate, and others might be used somewhat differently. I'm not sure we'll be doing whole body, X-rays. But the thing that they found, and this is a before and after study, not a randomized trial, was that they improved mortality, particularly in hospital mortality, uh, in these major trauma patients. So patient blood management in this regard, in this before and after well done observational study from Dr. Spahn and his colleagues really, I think, opened some people's eyes to the potential for improving outcomes in trauma patients using patient blood management and approaches that are also used in bloodless medicine and surgery. So these are some of the additional changes that they saw, including renal failure, infection rate, thromboembolic events. If you can avoid transfusion and maintain patients in a close to more physiologic state, it's an all-around win, both for the patient, for the team taking care of them, and for society as a whole and the hospital bottom line. So one final set of slides just showing that the comprehensive program of PBM in Western Australia, which is, I think, probably the only place in the world where an entire government entity has introduced these bloodless medicine and PBM type technologies and approaches. And you can see the folks who are the primary authors here. Um, in Western Australia, this has been going on for some time and basically has been used for everybody in the Western Australia is big geographically, but not very big in terms of population. But still, we're talking about 600,000 patients. This was published about 8 years ago in Transfusion. So what happened? What happened is they had, as we would expect from some of the individual smaller studies, they had decreases in length of stay, infection, bad outcomes for cardiovascular disease, such as myocardial infarction and stroke. And they actually did have a slight increase in readmission rates, for what it's worth. Probably patients who were not feeling well and uh, came back into the hospital, but most importantly, decreased mortality of about 28%. And the proportion of patients who were actually admitted to the hospital with anemia dropped by about a third. And they used a lot less blood transfusion uh, in this setting, and they didn't give as much blood transfusion to each patient. The savings to society in Western Australia were quite striking over 6 years. Um, probably in the hundreds of millions, certainly tens of millions of dollars. And unlike most medical advances, which require you to spend money to save lives, PBAC and bloodless medicine and surgery reduces mortality, morbidity, but actually saves money and makes money available for other things. So, in conclusion, our standard approach, which obviously the Bloodless Medicine and Surgery Society was founded to try to counteract the unfortunate effects of how we approach anemia and bleeding, which is blood transfusions, have been shown to strikingly predispose to bad outcomes, including infection and mortality. And anemia obviously is not a good thing, but transfusion does not fix the problem, except in it buys you time as a surgeon or an interventionalist to fix the underlying bleeding or anemia due to disease. So transfusion has that benefit in selected patients who are willing to accept it, but as a routine treatment, it fails to fix the problems of anemia and bleeding when they're not life-threatening immediately. We know that restricting transfusion or using autologous techniques where they're acceptable to the patient and the practitioner, this reduces morbidity, mortality in observational and randomized trials. And we're not going to be able to do randomized trials probably on a large scale for patient blood management or bloodless medicine and surgery, but where they have been implemented, as Dick Spence, a vascular surgeon, showed in witness patients many years ago, that he could get very good outcomes with bloodless techniques, better than in patients who were not witnesses who received transfusions. So that these approaches of bloodless medicine and surgery and patient blood management, as pioneered by, among others, Denton Cooley, is that rare health advance that these improve clinical outcomes, reduce suffering of patients, and reduces healthcare costs. So I will stop there.
Thank you so much, Neil. With Bruce piece, I think, as if I'm not wrong, we're supposed to hold questions until Sherry Ozawa hosts for us a nice discussion group after both after both speakers have spoken. So I think we'll just go forward. I think, Neil, you're spot on. I have quoted Neil over and over and over again all around the world, both for his pioneering views on immunosuppression, but for his very progressive view as a blood banker to say that, do we really know what we're doing? And I think that point, as he pointed up in the anemia discussion, is absolutely true. I'm right now in the midst of writing perhaps the most important paper I've ever written, to take a look at using hemoglobin as a trigger for transfusion. And I am convinced that's biologically and physiologically inappropriate, to use hemoglobin as the number. And it strikes me that although we continue to say anemia is a disease, I think it's a marker. I think it's a marker for what's going on with a whole body that's in crisis. When you look at how many different enzymes in our body and proteins are iron dependent, there's about 28 of them or so. So if you're, let's say you have 30% reduction in your red cell mass or in your hemoglobin, what's going on in your cytochromes? We always are worried that people don't have enough energy when they're anemic. And physicians say, well, that's because they don't have the oxygen carrying capacity. But if you reduce every cytochrome in every cell in your body, have you got the energy? So, I'm not here to give a lecture on that, but I think as we think deeply into what Neil said, it's vitally important to digest and think on that. I'm going to move us ahead. Thanks, Neil. Wonderful lecture. Really appreciate it. Our next lecture is to honor Ron Lapin. And I don't know whether he pronounced it Lapin or Lapin, as the French would say, but he's one of our heroes of bloodless medicine and surgery. Sarah Walbot is going to deliver that lecture for us, and thank you, Sarah, for doing that. But just let me say a couple of words about Ron Lapin. He was Israeli born and trained in New York City area, and then went to establish general surgery and such out in Orange County, Southern California. Orange County is an area just outside Los Angeles. And he established a number of centers of bloodless medicine there. But for me personally, he was one of the great supporters of perfluorocarbon oxygen delivery systems, and really got me going on a big part of my research career, which has led to things like patient blood management. Anyway, let me introduce Sarah. Sarah Walbot is a nurse, BSN. She's a seasoned leader in patient blood management with extensive experience in supporting healthcare systems and PBM programs. She serves as PBM manager at University of Utah. And she's an active member of both SABM as well as Bloodless Medicine and Surgery Society. She's got a clinical background in gastroenterology, operating room, and administrative nursing. And Sarah brings a huge practical and strategic perspective to PBM. She's passionate about her patient advocacy. And Sarah is co-founder and host of Let's Talk Patient Blood Management podcast that I would recommend to anybody if you ever get to listen to it. Beyond her professional work, Sarah is driven by a love for travel, storytelling, and lifelong learning. She's eager to connect with people and share her knowledge and inspire, and I'm sure she's going to give us a wonderful lecture here for us. Sarah, you're on. Thank you very much for your willingness to prepare and deliver this lecture for us today.
Thank you, Bruce. I will try to share my screen here. And hey, everyone. Good day to everyone. I think there's no place that I'd rather be on Bloodless Medicine and Surgery Day than with friends and colleagues who are eager to learn and advance bloodless care. Today, I'm honored to be able to highlight the work and the life of a hero in bloodless medicine, Dr. Ron Lappin. And I feel like his contributions in bloodless medicine have been largely forgotten. He's rarely mentioned in presentations, and he's quite difficult to research. By the end of this presentation, I hope that you too believe that he's a hero in bloodless medicine and has contributed much to the foundation of how patient blood management programs, bloodless care programs now exist in today. So much of my information that I'm going to share with you today came from this book, No Man's Blood. It was authored by Gene Church. And Gene Church spent 7 to 8 months following Dr. Lappin and his bloodless care team because he wanted to get a measure of this controversial surgeon. Dr. Lappin was often in the media, both with great praise. He was nominated by 15 countries for a Nobel Peace Prize for his humanitarian work, but also he was greatly accused. He fought many legal battles, both personally and professionally. So we're going to learn a little bit more about that. This is the beginning words that you'll see in the book. And the book is no longer in print, but if you search for it on Amazon, you can find used copies. So if you are interested in bloodless medicine history, I highly recommend obtaining a copy. But this was a poem that Dr. Lappin remembered from his childhood. It was penned by Martin Niemöller, a German theologian. And so when Dr. Lappin was asked why would you threaten your medical license for a small group of patients who have a religious belief against blood transfusion? He quoted this poem, and it says, "First the Nazis went after the Jew, but I was not a Jew, so I did not object. Then they went after the Catholics, but I was not a Catholic, so I did not object. Then they went after the trade unionists, but I was not a trade unionist, so I did not object. And then they came after me, and there was no one left to object." So for Dr. Lappin, he took up the advocacy for bloodless medicine more as a civil rights and justice. He felt that everyone deserved medical care. I'm going to talk a little bit about his life before Bloodless. Just like Bruce said, he was born in Tel Aviv, Israel in 1941, and he was abandoned by the age of 1 by his mother. And I think that this abandonment really shaped his personality. He struggled many times throughout his life, feeling like he was being abandoned by family members, by peers. And also he had almost the inability to abandon someone, especially if they were helpless or in need. He was described as very dedicated to his studies. He was very determined and confident in his skills. He didn't fit in with the social life of college life. He was too focused on becoming a good surgeon. He did an internship in Brooklyn, New York, a surgical internship, and that is where he actually discovered the electronic scalpel, or the Bowie knife as we know it today. And he was able to use that electric scalpel on animals in his cardiac research. So he got very good at using it, but it was not approved for use in human surgeries, and he spent many years advocating for its use because he could see the benefits in the blood conservation. So in 1973, Dr. Lappin moved to California to begin his practice. He was warmly welcomed by his peers, and he quickly gained a reputation for quality and excellence. But soon his colleagues felt that they were losing patient referrals to Dr. Lappin, and so they began to feel threatened. And the colleagues began to criticize his work, and they're scrutinizing his charts looking for errors. Of course, this brings up the abandonment issue for Dr. Lappin. He doesn't really understand, why he's being rejected, but he makes a decision to take other surgeries that surgeons reject because he feels like, well, how can they scrutinize or be upset at my work if they've turned that work down? So it isn't long before he meets Dennis and Maria. Dennis calls him very desperate. His wife, Maria, has experienced a ruptured ectopic pregnancy, and she's in a hospital about 20 minutes from where Dr. Lappin practices. Because she presented with a hemoglobin in the high sixes, the surgeon at that time told her he would not do the life-saving surgery unless she would consent to a blood transfusion. And because of Maria and Dennis's religious belief, they could not consent. So the hospital system actually told them that they needed to take her home and prepare for her death. They did give them 1 hour to try to find another surgeon that would take over her care. So Dennis called 17 more surgeons who declined the surgery, and Dr. Lappin was his 18th call. And Dr. Lappin was kind of impressed that someone would stick to a religious belief, even in the risk of facing death. And so he told Dennis, "Get Maria to me as quickly as possible, and I will treat her and I will not give her blood." And so Dr. Lappin assembled his surgical team, and he actually told a lie to the anesthesiologist. He told the anesthesiologist that Maria had a rare blood type and that he had called the order into the blood bank and that the blood would be on its way, but they could not wait for surgery as she was hemorrhaging inside. And he said that he did this because he did not want to take the time to argue with the anesthesiologist or administration on performing surgery. And so he successfully performs surgery on Maria, and he actually stays with Maria the first couple nights in the hospital just to make sure that she's doing okay and that the large doses of iron and EPO that he's giving her is trending her in the right direction. So during that time, he gets to know Maria and Dennis pretty well, and they tell him all about their Jehovah's Witness beliefs and why they are so solid on not taking blood transfusion. After Maria is discharged, it doesn't take very long, and he receives a call from Nathan. Nathan has heard Maria and Dennis's story, and he's calling Dr. Lappin, hoping that he will also treat him. So physicians had declined to treat his rectal cancer without blood for 2 years. And so because of this, Nathan was seeking alternative therapy at a Mexican cancer clinic in Tijuana, Mexico. And Dr. Lappin was so saddened by that people were actually so desperate to receive medical care that they were traveling to Mexico for alternative therapies. But if you were a Jehovah's Witness in the 70s, 80s, and even early 90s, you likely knew someone who was traveling to Mexico for treatment. So when Nathan gets to Dr. Lappin, he's experiencing intense pain in his rectum. It was nearly closed off due to the large tumor growth. And Nathan tells Dr. Lappin before surgery, "I have no money for this surgery." Dr. Lappin explains that life is always more important than money and not to worry about the money. And he goes ahead and he does major surgery, removing the tumor and the colon for Nathan. Before Nathan is discharged, he tells Dr. Lappin, "I want to make an introduction. Please accept the meeting invitation that is going to come your way." So it's not very long where Dr. Lappin finds that he's sitting across from 3 Jehovah's Witness elders in his office. These elders are also businessmen. They have a health insurance company, and they were seeking a qualified physician to support the bloodless care community. They tell him that they will fund a nationwide hotline to be established, and then they will dispense that phone number all throughout the nation, and people will be able to call and get advice and also possibly treatment for their medical crisis. And so the 1-800-NO-BLOOD number was established. And if you were a Jehovah's Witness in the late 70s, the 80s, and the early 90s, you absolutely knew this phone number, and you knew it felt like a lifeline for you, that if you were in a medical crisis, you could call it 24/7. days a week, a human would pick up and they would either advise you or they would arrange your treatment. One of the gentlemen that he was sitting in his office that day was a retired surgeon. His name was Herc Hutchins. And Dr. Lappin really focused on Herc Hutchins, and he became fast friends. He calls Herc Hutchins his mentor. He speaks to Herc Hutchins and very quickly pulls him out of retirement, and he ends up partnering with Herc Hutchins and his anesthesiologist, Frank Garcia, to create the Institute for Bloodless Medicine and Surgery. And to my knowledge, that institute is the very first bloodless care program that was established in the United States. If I'm wrong, please tell me, but they go on to create many of these. So if you type the title of this slide into the YouTube, you will come across about a 30-minute video. And if you're interested in the history of bloodless medicine, I highly recommend the video. I'm going to show you a couple clips today how the Institute was ran and operated.
3 years ago, Dr. Lappin and a team of specialists formed a nonprofit teaching organization, the Institute of Bloodless Medicine and Surgery. Physicians in the group travel widely in the United States and abroad, teaching lay people and doctors the technology and potential risks of bloodless techniques. As a result, 350 more doctors have joined the Institute.
Oops, I'm sorry. I'll start that over.
3 years ago, Dr. Lappin and a team of specialists formed a nonprofit teaching organization, the Institute of Bloodless Medicine and Surgery. Physicians in the group travel widely in the United States and abroad, teaching lay people and doctors the technology and potential risks of bloodless techniques. As a result, 350 more doctors have joined the Institute, and membership grows each month. Separate from that, Dr. Lappin and his associates run busy practices in Norwalk, California, to which patients come from as far away as Alaska, Florida, and overseas. The office runs a 24-hour toll-free hotline, 1-800-NO-BLOOD.
Linda, there's a hotline call on 8.
This is Linda. May I help you? No, it's not enough to put the question of blood pamphlet in your file. There are ways to protect yourself.
The hotline rings about 60 times a day.
So this is a photograph of a 1980 Awake article that was printed by the Watchtower Bible and Tract Society. It was one of the two journals that Jehovah's Witnesses often used in their ministry work. And it pictures a Dr. Ron Lappin standing beside his elderly partner, Herc Hutchins, treating a bloodless care patient. And this is a screenshot of that same article on their online website. And the name of the article in 1980 was Where Patients' Wishes Are Respected. And what stood out to me is in that second paragraph under medical care, where Dr. Lappin says, I would never give blood to any patient. Lappin explained, I haven't given a blood transfusion in over 5 years. And so what we see here is that by 1980, Dr. Lappin, what was once a civil justice pursuit for him, he now really believes in the science of bloodless medicine. And he traveled throughout the United States and abroad, talking to both lay people and to medical community about how to handle bloodless care cases in times of crisis. When he was in Australia, he did a radio interview, and we have that radio interview. And so I'm going to share some clips from that radio interview with you now. And what you'll hear from this first clip is that he states that very fact that he now believes in the science of bloodless medicine.
So I'm very glad that I've had the opportunity to work on these people because it has made me a better surgeon. And pretty much have dedicated my life to try to help a group of people who have been treated as second-class citizens in the eyes of the medical profession for years. I've done it as a civil rights issue at the beginning. I then became scientifically interested in it, and today I'm glad for it. So I'm very glad.
I'm going to share two more clips from this radio interview, but again, if you type in the title of this slide into YouTube, you'll be able to hear the whole, I think it's a 13 to 15 minute video. But here we hear Dr. Lappin telling us that donor blood is dangerous, blood is an organ, and that transfusion is a transplant.
Blood is probably the most dangerous substance we use in medicine today. Probably kills more than any other drugs that we use. And it should not be used as the first line of defense, but rather the last. I think the problem that is the most complicated and will never be conquered is the fact that blood is an organ transplantation. By definition, when blood is an organ, because an organ is any system that performs a specific function. Giving patients a couple of units of blood from another individual essentially gets you married to a couple of people, genetically speaking, for the rest of your life. You know nothing about their backgrounds, and the rejection phenomenon does occur as it does with any other organ.
Okay, and I was surprised. I kind of thought that the blood is an organ was kind of a more modern idea that we were promoting. But as back in the time era of the mid 80s, and where the HIV crisis and people were being infected with hepatitis, Dr. Lappin was teaching that. Forward. Okay, and in this last clip, we'll hear that donor blood is an immunosuppressant. Well, he'll talk about the mortality of cancer patients and how we could easily reduce transfusion by 50%, and that it's the patients ultimately that are paying the price.
We've only become aware of the immunology aspect of blood in the last maybe 10 years. We now know, for example, that cancer patients who are transfused die quicker than those who are not. That's cancer of the colon, the lung, the breast. We also know that it is a tremendous immune suppressor. And as such, having all of these inherited problems should be used as the last line of defense. With some care and a little bit of understanding of all of the inherited problems, we can reduce by 50 or 60% very easily without endangering any lives of patients the quantity of blood that is given to patients today. Because I think the majority of the blood that is given to make the doctor feel better, not the patient. But it is the patient ultimately that pays the price, not the physician.
As Dr. Bruce mentioned earlier, he was chosen to be one of the first physicians to do research with oxygen transport fluids, and he believed in these non-blood oxygen carriers very much. We can see his studies here. He really did feel that this was the future of medicine and that we've become less and less dependent on blood and the risks associated with transfusion. And we're going to show a clip that kind of highlights some of his work and his work in that arena.
A hemoglobin of 10 is the cutoff. Below that, doctors fear the body's blood lacks enough oxygen to safely handle anesthesia. Most surgeons and anesthesiologists would insist upon transfusion or refuse the case. But Dr. Ron Lappin is not an average surgeon. He is a pioneer in bloodless surgery and its leading authority internationally. Since 1973, Dr. Lappin has treated more Jehovah's Witnesses than any other surgeon in the world using the bloodless techniques he has developed. He has never once used a transfusion. While most surgeons won't work below a hemoglobin of 10, Dr. Lappin's average patient goes into surgery with a hemoglobin of 7. He and his team are at the forefront of current surgical techniques. For example, they were the first to use an artificial blood, and they did so with great success. They continue to press for its FDA acceptance. Dr. Lappin's patient today is a 76-year-old gentleman with a life-threatening aortic aneurysm, a ballooning of the aorta. He has been turned down by other doctors because an aortic resection usually means blood loss and transfusion. Dr. Lappin is able to perform the surgery successfully without relying on blood.
All right. Well, thank you for coming tonight, guys.
What impressed me the most in this video, and this is the last video clip I'm going to show you, is that he didn't just advocate for the use of bloodless medicine as a choice in adults. He also advocated for children as well. And we're going to see this story of a young pediatric patient.
Tanya Ronnie's case, like Bruce Hedrick's, began with a phone call to the 1-800-NO-BLOOD hotline.
The doctors there won't do it without blood. Okay. Can you hold on, please, and let me get Dr. Keller for you? Hold on, please.
Yes.
There's a hotline call.
Excuse me a moment.
Tanya, 12, is in a hospital in Lodi, California. 2 days ago, the family car was in an accident. Tanya's parents, both Jehovah's Witnesses, were killed instantly. Tanya is in shock with a badly fractured right thigh bone. She is in considerable pain and her grandfather has just called the hotline for help. Because of Tanya's unwillingness to accept blood, doctors in Lodi are refusing to set her leg. Just 3.5 hours later, a Learjet brings Tanya, her grandfather, and a medical flight crew to Long Beach. Luckily, the fog that had threatened to close the airport has lifted in time. This airlift emergency response is just one of many that Coast Plaza Medical Center will arrange each month. Tanya's leg is in traction and moving her is difficult. With special care, she is transferred to a waiting helicopter. The flight crew must provide basic medical care as well as kindness to a traumatized girl. Equally important, they must get Tanya to Coast Plaza Medical Center and to surgical treatment fast. It is a 15-minute flight to the Norwalk Hospital. During it, Tanya's vital signs are watched carefully. The weather is clear and the ride smooth. The pilot is in constant touch with his dispatcher, who in turn keeps the hospital, the institute staff, and the local police alerted to the exact minute of landing. Dr. Lappin is called back to the hospital after working a long, full day. It is a frequent occurrence, not just for him, but also for Dr. Kaller, Mikey Waring, and the rest of their staff. The thought foremost in all of their minds is, what needs to be done to take care of this patient? By the time Tanya's helicopter begins to land, everyone is prepared.
Okay.
As soon as Tanya is comfortable, Dr. Kaller and Dr. Lappin assess her condition and carefully begin to prepare her for surgery.
And what we're going to do is we're going to go ahead and make a little incision here on the side, and then we're going to put a metal pin in there, okay? And that would keep your hip with the area that was broken all cemented together. And that will allow you then to just continue to move like you were before the accident.
Tanya is operated upon successfully without a blood transfusion. Had she stayed in Lodi, her doctors planned to apply for a court order, allowing them to give her a blood transfusion. Court orders are a very serious concern for witnesses of any age. If the patient is a minor like Tanya and might die without additional blood, the court may issue an order authorizing a transfusion.
As you can imagine, seeing the work that he did, many of his peers felt that he was grossly acting outside of the standards of practice for that day. And so many opposition and accusations came his way. He was reported to the Board of Medical Quality Assurance, where a nearly 5-year legal battle takes place where he's fighting for his medical license. He was in the first beginning stages offered a 1-year license suspension, to which he declined. He continued to fight and do his work with the bloodless care community. The accusations against him were inappropriate surgeries, unnecessary surgeries, surgeries that did not align with the standards of practice, and unnecessary removal of organs. As you can imagine, this would be a very stressful situation for Dr. Lappin, and it did take a toll on his personal and professional life. And we celebrate May 16th because of the work that Dr. Denton Cooley did, but the date of May 16th has significance for the life of Ron Lappin as well. On May 16th, 1986, the Attorney General of the state of California withdrew and dismissed all of the accusations against him, stating that they could find no unethical behavior or poor medical practice. And it is even important to say that the lawsuits that were brought against his personal life and conduct too, and it ended with the same results. And then on May 16th, 1995, Dr. Ron Lappin tragically dies at the age of 53. And the author felt so compelled with all the time that he had spent with this bloodless care team to write his own thoughts on what he's seen and observed. And he titled that at the end of his book, The Penalty for Leadership. And it's a beautiful piece. I recommend that you read it, but it all kind of boiled down to the statement that he makes here on page 273. He says, those who proved to be outstanding leaders in their own field were assailed by their peers out of envy, personal disappointment, spite, or ambition. Unable to equal or excel, the follower seeks to depreciate and to destroy. And the very last words in the book is a quote from Albert Einstein that says, "Great spirits have always encountered violent opposition from mediocre minds." And so, for my concluding thoughts, I think that Dr. Ron Lappin absolutely was a hero of bloodless medicine. And I think that what set him apart, I think we have many heroes of bloodless medicine in history and today, but he had unwavering commitment to bloodless medicine and the science. He adopted bloodless medicine not out of a cultural or religious belief, but because the science and the patient outcomes told him so. And he refused to use blood in his clinical practice. And again, out of that statement for penalty for leadership, the author writes, "That which is exceptional makes itself known, no matter how loud the clamor of denial. That which deserves to live, lives." And today, bloodless medicine and surgery still lives. And so may we follow Dr. Lappin's example as we try to lead the medicine towards a more bloodless future.
Thank you, Sarah. Thank you, Sarah. That was absolutely wonderful. Adrian, I didn't mean to usurp the comments there. Go right ahead.
Oh, I was going to say thank you too. And I'm excited to look for that book. That sounds
Yeah.
like a fascinating read.
Yeah.
Yeah, that's fantastic. And I think some of the people here can relate in that they either have been personally persecuted or they find that they continually push the rock uphill. I know Neil Blumberg has been actively persecuted by people in his specialty. I'll tell just a quick little note that when I first, in 1987, wrote my first NIH grant requesting $3.7 million to study reducing transfusion and heart surgery by using thromboelastography to make decisions, I was told several things. Number one, please lose our address of the NIH. We know that every person who undergoes heart surgery must be transfused. Number two, we know that thromboelastography is voodoo, worthless garbage, and that by trying to reduce transfusion, you will make patients worse in heart surgery. Quote the NIH. I have it in my letter from the NIH. Please lose our address. Now there are over 10,000 articles on the subject, and it's widely accepted to make a difference. I know Neil and his goals of studying immunosuppression have undergone similar kind of persecution. So thanks, Sarah, for putting that in very clear view. And the next person who's going to speak has also been persecuted. Sherry Ozawa really needs no introduction because I'll take the next 2 hours to talk about Sherry's incredible accomplishments, including being, speaking around the world, leading.
Sorry, Bruce. We're taking the Q&A first and discussions.
Oh, Q&A first. Sorry, go right ahead. Maybe Adrian wants to start going with Q&A.
See.
Do anybody want to raise their hand? Any questions? Neil, I'm going to ask you a question, how you got started and how you got interested in immunosuppression. What made you as a blood banker say, I see there's something here that just doesn't ring true? And because that was going countercurrent to everybody else's beliefs.
Well, there's another forgotten pioneer in this field, who some of you may have heard of. He's a surgeon named Paul Tarter. And in 1982, in The Lancet, he and Louis Burrows, who was a renal transplant surgeon, Paul was a house officer at Mount Sinai, they reported that when they examined the data in a trial of adjuvant immunotherapy, I think it was immunotherapy in colorectal cancer, Louis Burrows, who's a transplant surgeon, was aware of the data that patients who got renal transplants who'd been transfused actually had better outcomes in terms of graft survival in the 1960s and 70s. And he said, if transfusion is improving outcomes by presumably immunomodulating, they didn't use the term at the time, patients the way we are with the only drug that was available for renal transplant at the time, azathioprine, was considered an immunosuppressant, which it is. They thought this might be bad for cancer patients, so they looked at the survival of transfused and non-transfused patients and published these two curves which were astounding. And my wife and colleague, Dr. Joanna Heels, a hematologist oncologist by training, and I looked at it and said, well, that's got to be wrong. In fact, nobody believed the Terasaki and Opel's data that transfusions made transplants better. And so the shorter version of this is we said, well, let's look at the population here in Rochester. And one of our residents, a resident named Mukesh Agrawal, found exactly the same thing that Tartar and Burroughs had. And it was a stunning thing for us because nobody had suggested to me, and I certainly hadn't had the idea, and Joanna hadn't had the idea that transfusions were like an organ transplant, as just mentioned. In fact, I hadn't heard the expression until many years later. And so we got interested in this notion. Wait a second. And then Paul Tartar also published data showing that postoperative infections were worse, more frequent. Uh, and as a physician who was primarily responsible for supporting other physicians and nurses through transfusion, it seemed very important to find out what was really going on because, it's all well and good to have dogmas, but data is much better.
So thanks, Neil. That actually rings true in my life. I was trained at the Mayo Clinic and then practiced for my first few years at Rush in Chicago in the mid to late 70s and early 80s. And I recall very clearly doing early kidney transplants and being told by the surgeons that I must transfuse, even if the patient is 13 to 14 grams per deciliter, because they knew they had to be immunosuppressed. And that has run true with me for the rest of my life. That this was what's true on one hand has to be true for other things too. So and I brought that up. I will tell you also another personal story that in the early 1990s, I looked at blood transfusion for heart surgery and asked the question of a database of 4,000 patients. And the question was simply, what's the best hemoglobin hematocrit or the best transfusion rate to go into the ICU? And lo and behold, to my utter amazement, it was the lowest hemoglobin and the lowest transfusion rate. And when we published that changed my entire outlook on what should we do in heart surgery. And I don't know whether that one particular paper triggered others to start asking the question, but it certainly led to a number of people saying, well, in heart surgery, what should we do? So the other thing I would like to ask many of the participants here is, how do you feel around the world? Nathaniel, many of you folks in Africa, I'm sure, and many places around the world, I'm sure feel as though you're not supported by the main medical leadership that you have to deal with.
So if I may kick off the answer, thank you, Bruce. I can stratify the answer in terms of when I started and that's later on and now. So I could say that when I started, there was a lot of opposition, both from my seniors, my peers, juniors. Everybody thought I was crazy. But the key thing is to have the science available. That is the journal articles and the research work, and to share this and to invite criticism. And the way I invite criticism is to ask for any article that opposes what I have said. Is there any journal article that you can show to me that shows the benefit of blood transfusion, or that shows that patients who are transfused come out better in terms of the standard outcomes? Of course, people go home to do their research and they are not able to find a single journal article. So I allowed for people to criticize, and of course, I made myself available for the work in various subspecialties. So people could call me from obstetrics, gynecology, orthopedics, wherever, cardiothoracic, even though I'm a general surgeon. And I would always be there, and I wouldn't charge any money. So as time went on, people got to realize that it works. And of course, for my own patients, I do bloodless for everyone, whether JW or not. And after people were waiting for my patients to die off, and they weren't dying off. So with time, we then had a buy-in. People started getting interested. When I started, it was only one anesthesiologist that would anesthetize for me. That is Professor Laurie, who is now the chair of the Faculty of Anesthesia, West African College of Surgeons. I think she made a comment yesterday. So, but as time went on, we started to have people who were, opposed, joining. They became members of the Bloodless Medicine and Surgery group that we formed in my institution. Of course, Laurie was a founding member. We had some founding members, but then we now had others, so that at this time, I think almost all the anesthesiologists in my center are members. And then I had to go out to departments to speak, request opportunity to share information with various departments, because they say charity begins at home. I started with my home department, surgery, and went round. So I can say as time went on, the resistance grew less and less. At this very moment, I can say that it's like zero resistance, because years have passed and people have seen that the bloodless actually works. And at a point, some patients had to claim that they are Jehovah's Witnesses in order to get access to bloodless care. So but that is changing now. Many of the people, the surgeons, the anesthesiologists, they straight away use bloodless techniques. For instance, bloodless cesarean section is routine. It's routine in my center. So it doesn't really matter who you are, the use of tranexamic acid, vitamin K, and so on. So they do that routinely, and residents do it. It doesn't even have to be the attending or the consultant. The residents routinely do emergency cesarean sections. If somebody actually declines blood transfusion, there's zero opposition. What we are now waiting for is the full institutional buy-in, because up till this moment, we're still not being funded in any way. We're just volunteers. We use our own resources. Sometimes we even spend money on our patients to make sure that they get well and there's no negative outcome. I'm sorry, I didn't mean to give a full talk, but I'm trying to answer the question, and I hope I have.
Yes, thank you. We actually have a question in the chat that kind of goes along the lines with that, asking about what types of data literature have been the most successful when trying to shift these providers' perspective or gaining their buy-in.
So I can answer that with a story. Very few people here realize that Dr. Spies has been a pioneer. Dr. Spies has been a pioneer. I spent my life professionally since 50 years ago as a resident studying platelet transfusion. And then Dr. Spies and colleagues published a paper showing that in cardiac surgery, platelet transfusion actually harmed patients. This was a real shocker. I was actually one of the reviewers of that paper for Transfusion, Bruce. And
for taking the paper. Thanks for allowing it to be published.
Well, I fought very hard for it to be published. As you know, there was a very prominent transfusion medicine doctor and hematologist who later said, well, this is probably just confounding, blah, 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 in an editorial. But it really started an entire change in our research here in Rochester about platelet transfusions to search out to what was going on. And we've learned a lot about platelets and platelet transfusion due to research in many centers showing the platelets are not just a hemostatic, I mean, they're part of the immune system and they have pro-inflammatory, pro-thrombotic properties as well. Anyway, so I think data make all the difference. And, obviously you can design scientific studies that give you the answer you want if you're careless, as opposed to just asking the question and seeing where the chips fall. And I think that's what you did. And so we know a lot more about platelet transfusion today than we ever did before. And you and your colleagues are the reason.
Well, thanks, Neil.
You gave us data.
Well, thanks. And I've just recently learned a lot more from you as well, in terms of understanding that, platelets carry the same HLA antigens on their surfaces as do red cells. And there's not a single cardiac surgeon anesthesiologist in the world that will give either type specific or cross-matched platelets. And so I've just been tasked recently to take a look at the cost of these therapies. And there's also no anesthesiologist that will give a unit of platelets and then retest to say, did I really make an effective difference to their whole blood coagulation? And if you then go to the hematology oncology literature and you say, well, really, how many dosages of platelets do we have to give to reach a target wherein we've hit our goals? It's usually 4 and 5 dosages of platelets because they're not being typed or given, and the HLA antigens get attacked. So my thought is that, as we now get new technologies that within 10 to 20 minutes, you can see whole blood coagulation. Maybe we can make some differences in targeting our therapy. I'd like to want to ask one other provocative question of people. I've just been tasked to write a big journal review of why patient blood management hasn't caught on worldwide. And a human factors engineer said, you need a crisis. And the crisis we had that made a difference in blood transfusion was the AIDS crisis. So is there a crisis looming in the future that will shake medicine up to say, these people were actually correct? Because, I love having all the data. I love having all the data that you and I and all these other wonderful people here put forward. But the data is not changing the vast majority of people. What is it that's going to shake people to their core to say, hey, these men and women were correct? And I don't have a crystal ball to look into that future. We just had the COVID crisis. The world went through an absolute blood shortage, and I went to the United States Congress to say, you have a way to fix this. It's called patient blood management. Nobody wanted to listen. I don't know what crisis it'll take. Nuclear war? I don't know.
Well,
but
I'll just chime in. I mean, I think before there was AIDS, we didn't know about AIDS. So you always have to think what else is, may get through.
Yeah, exactly right. Before AIDS, we didn't know about AIDS. Before COVID, we didn't know about COVID. Before what's coming, we don't know. Yeah, thanks, Mark. I mean, but I thought it was so insightful for this human factors engineer to say, every now and then medicine lurches ahead. And clearly with the COVID crisis, we've learned a lot more about immunology and vaccines and stuff, but this therapeutic insight that we have both with bloodless medicine and with patient blood management is awaiting some epiphany by medicine. And I don't know what it's going to take for the epiphany to occur. All of us heretics keep getting burned at the stake, and someday the heretics rise up and you got a You got a new religion. The new religion is data. Any other questions we have out there, Adrian? You see any other questions? For some reason, questions aren't showing up on my chat.
Yeah, this is actually for you, Bruce. It says as a BMS coordinator, I see 50% of people not wanting transfusions due to the mRNA and antibodies. Well, it's not a question, it's a statement more, but he's saying maybe COVID will be the tipping point. But we've seen that too in our system. We have a lot of patients that are refusing blood products because of that mRNA and the antibodies, that vaccine. They do not want anything to do with it.
Yeah, well, there goes data being used the wrong way, or politicization of data. I mean, I've actually heard this. I was on an airplane over the last week. I've been on many airplanes over the last week, and somebody found out I was a doctor, and somebody found out I was a doctor having to do with medicine and transfusion. And I said, first question was, is this COVID thing real? I don't know how you even answer that except to say, I said, you know, COVID was the worst disease as a doctor I've ever seen in my life. It's the only disease in my life where I've had nightmares from it, from what I saw. And yeah, it is real. And then the next question was, so if I get a blood transfusion and I get the messenger RNA from, I said, you know, you have gone down a very dark, deep rabbit hole that has not based on any data or reality. I don't know what to say to people like that because they're believing lore just as bad as the physicians who believe the lore about, you know, transfused to 10. It's the same level of acceptance of lack of evidence. But yeah, I mean, there's no reason for that whatsoever.
Yeah, that could be a discussion for a whole day.
Yeah, it is
But
a discussion for a whole day, and it's a discussion about, you know, what's the mechanism of messenger RNA vaccines. It's a very localized, very short acting event that makes the protein that then the body can recognize and make the antibodies against.
Do you think that Adrian makes a good point, though, that it is going to take patience, right? Patients no longer believing, you know, whether it's belief or, but it is going to take patience to, you know, the more and more patients who realize there's alternate therapies and that they want their blood handled correctly, then as they did with the bloodless care population, they will have to use patient blood management.
I simply asked many of my patients when I was still in practice, if you wish to have, does anybody wish to have a blood transfusion? There's not a single person. And then I asked the next question, do you want my DNA? You know, do you want to look like me? Oh God, no. Do you want my immunology? No. You know, you want all the other 20 million viruses that live in me that nobody's ever characterized? You're going to get all of those and then some.
But isn't that the problem, that patients aren't really given a proper consent?
That
They're
is
just told that they need a blood transfusion because, you know, it's going to help them raise their hemoglobin level. They'll feel better. Their wounds will heal.
That is 100% the problem, Mark, is that you get the lowest level intern to say, go get a consent for blood. And on the consent for the blood, it says your doctors know when you need a transfusion. There's lie number one. And your doctors will decide when you're critically ill enough that you need this. There's lie number two. I mean, it's just a pack of lies. And you know, physicians, and it's the worst of paternalism. I once wrote an editorial about how the paternalism of medicine has persecuted Jehovah's Witnesses, and it's because the paternalism is, don't you dare question our rights as physicians to tell you what to do. You know, the Hippocratic Oath is in some ways all about paternalism, Hippocrates wanted to make sure that the lay public never really knew what the physicians knew, because if they knew what you knew, they might question your ability to be a good physician. Don't let them know, why do we speak in Latin terms and other things? It's to keep the lay public from really knowing what the hell we're talking about. I never wore a white coat to see a patient because I don't want a patient to be put off by that symbolism. How many times do you see people walking around with a stethoscope around their neck? What are you going to do with that thing? What are you going to do with that thing other than just make the patient feel like you've got a status symbol?
I think Kathy Carter has a comment in the panelist group.
Hi, everyone. I'm just here as a patient. I think one thing is that the fact that patient isn't given enough information that they have choices. And if they knew the benefit of alternative bloodless surgeries, and they knew if they received blood, the difference, which one would they actually choose? If they knew if they took on blood transfusion, how it would alternate their DNA, how it would change their life, they might be reluctant to draw to blood transfusion, opposed to knowing the benefits of not taking blood. I think that's a subject that people should look into more and educating them. If you take blood, what would happen to you, opposed to not taking blood.
Yeah. Thank you, Ms. Carter.
You are spot on that, knowing the truth gives you the chance to make the correct decision. The original people in the 1600s and 1647 that did first blood transfusions were all members of the Templar Knights. The Templar Knights said, truth will set you free. And so the more truth we can get to our patients, the more they can make the individual decisions. It's just how to get them that information.
Yeah. Well, with the patient on now, should we move on to our panelists?
Sure, absolutely. Sherry, you want to introduce our panelists? I pre-introduced Sherry, but I don't think Sherry really needs any great introduction.
Hi, Bruce. Thank you. Can you hear me okay?
Yeah, we got you.
Okay, thank you. Sorry, I'm calling. I'm connecting from Belgrade, Serbia, so it's a little bit noisy. I apologize for that. But I think Nathaniel was wanting to co-host as part of the session, but that's perfectly great. So I'm here.
Yes, I'm with you, Sherry. And,
okay, so we have.
Bruce, please, you still introduce Sherry again because she wasn't around before.
Did you say that to Bruce or to me? Yeah, Matt.
Please.
Oh.
We're saying that Sherry might still need an introduction, even though she's a familiar face.
Could everybody mute themselves if they're not the person who's supposed to be talking? I was just gonna say that Sherry's been one of the absolute leaders in patient blood management, and from her work at Englewood Hospital all the way through various different organizations, and now with Bloodless Medicine, Sherry is an absolute leader. If you look at the look at the literature on patient blood management, her name is all over hundreds of manuscripts, both with people that she's collaborated with, the absolute leaders, and she's been the immediate past president of SAVM, and led that organization to really embracing that blood is an organ. And why should that be a great epiphany to anybody? We just heard that, Ron Lappin said it years ago. How do we get that embraced by all of medicine and physicians? I think Sherry's leading a charge worldwide to get that thought. So Sherry's going to introduce panelists to discuss for the next maybe half an hour or so more, I think, about orthopedics and bloodless medicine. Anyway, Sherry, thanks very much.
Thank you, Bruce. Thank you for those kind words. I really appreciate it. And I guess to everyone's points, interesting. I was recently in Europe talking about that subject of blood as an organ, which I think certainly everyone on this call and previous generations agree with. And one of the folks in the audience said, well, where do you go to get that to be a decree? We all think so. And I said, I don't know. I can't actually answer if there's sort of a governing agency globally that decides which organ is an organ. So probably a topic for a different day, but I think there's much more to be written on the subject. And of course, we certainly know a lot more about blood than we did before, thanks to the work of many people on this call and others. But I'm sure there's more to learn. Like with most of our organs, we've probably only scratched the surface of how miraculous they really are. So anyway, thank you for the kind introduction and congratulations. I'm sorry I wasn't able to join you earlier in the week. I've been traveling overseas. But happy to be here now to wrap up this section of the meeting along with Nathaniel. And as we said earlier, or you all said earlier in the conversation, our patients are at the center of bloodless medicine and of course with patient blood management. That is the focus of it and what makes it different from optimal blood use. It is really about the patient, not about any product, not about any treatment, not about any service, but it's about the patient and what's right for the patient. A personalized medicine that also, of course, is scientifically sound, but respects patients' own feelings and beliefs. So I think that, again, is not news to anybody on this call. That's why we're all here. But we have with us a couple of folks that have personal experience and personal insight to give us. We have Kathy Carter, who is also from the East Coast of the United States, like me, who's going to tell us about her experience, and also our friend Samuel Udom, who is, I believe, from your part of the world, Nathaniel, sharing his experience. So, Nat, did you want us to have me start with Kathy and some of the questions that we prepared for her?
Yes, thank you very much. First, let me introduce myself as one of Sherry's students in Bloodless. Sherry actually gave me a written exam in patient blood management, which I passed. And then I got a certificate with her signature. She was then president of SABM. And I also spent time with her at Englewood Hospital Bloodless program. And so I'm very proud and happy to be with her on this panel discussion. I think we will kick off with Kathy, who has already been sharing some insights with us earlier in this meeting. So you're very welcome, Kathy, once again. You had bloodless surgery, as I learned. You can unmute your microphone. So please tell us, what was this bloodless surgery you had? When did you have it? And why was it necessary for you to have surgery?
Well, I had my first one in 2004. It was a hip replacement surgery. I had erosion cartilage breakdown, and so it was needed to take place. I had 3 in 2004. I was dislocated twice, so they had to do the surgery 3 times. My 4th one was 2015. Same hip, right hip, tissue and bone breakdown. Between 2019 and 20, I had a torn meniscus in my knee, and I had another bloodless surgery that was needed.
All right, thank you. So let's get this right. Do you know the name of the surgery that you had, or surgeries?
The first one was resurface hip replacement. And then the fourth one was total hip replacement in
Those are
2018.
those are major surgeries, and these are orthopedic surgeries. Was it your choice to have bloodless surgery? Because typically
Absolutely.
they ask for the number of units of blood for this kind of surgery.
Absolutely. Once I knew the benefits of having bloodless surgery, the possibility of healing quickly, not having my DNA altered. I have a weak immune system, so I've had that since I was a child. So it was very important for me to get the proper care that I would have without worrying about my immune system being altered.
So tell us how you went about seeking for and obtaining this bloodless care.
Well, I did some research as a Jehovah Witness. I was provided information on bloodless surgeries. Then my husband and I went to Englewood Hospital, and we saw a video of the process and how things work. And so I was very happy in gaining that information. So it was a win-win for me.
You went to my alma mater in bloodless surgery. That's
I love that hospital.
all right, that's nice. So do you have any idea what steps did the doctors take to ensure that the surgery was successful?
Well, initially in 2004, there was a little struggle because the doctor had to find other doctors who were willing to do surgery without the blood. But after that, he assured me that everybody was on board, that there was the bloodless substitutes were available for me, and that they would do everything that was needed to make sure I get the best care that was provided. And I only lost one teaspoon of blood.
Wow, that takes us to the next question. How did the surgery go, and what was the outcome?
It went awesome. I healed very quickly. I was released, I think, out of the well, as I say, 2004 was bad because I had dislocation, not due to the surgeon, but different techs with x-rays and so forth when they were moving my body. But other than that, I healed nice. There was no infections. I didn't get any infections at all, which I was happy about. It was nice. It was pleasant. I had no complaints.
That's wonderful. So that almost makes the next question redundant. Do you have any regrets for choosing bloodless surgery? And
No.
were there any benefits? You've told us some benefits already. So
Even
right.
I'm sorry.
Right.
No, even if I wasn't a witness, bloodless surgery is the only way to go for me. You know, knowing that, as I stated, I don't have to worry about tainted blood. I don't have to worry about infections or, my DNA being altered, because that's very important to me. I've had a family member that happened to, and he is unfortunately, he still suffers today from man-made error. But I don't have any of those worries. I just know that once I do have the surgery, it benefits me in every aspect.
I agree with you completely. Patient's blood is the best blood. That's the theme of the World Bloodless Surgery Day, which is today, May 16th. And our hero of the day, Dr. Ron Lappin, would have agreed with you if he were here. I think he's here with us in spirit through Sarah. So do you have any final thoughts you would like to share with the audience?
No, I think things like this conference and back during the day before the COVID, we used to have seminars at hotels and so forth, educating people on bloodless surgeries. I think this is something that has to take place. People has to know the benefit of bloodless surgeries and that it's a better way of living. They don't have to worry about different things happening to their body. They don't have to lie about being a witness. Just knowing that this is the best way to go in terms to a better health and that they don't have any worries while they, have to have surgery.
Thank you so much, Kathy, for sharing your experience with us. At the time you had the surgery, I believe Sherry was the clinical director of the Bloodless Medicine and Surgery program in Englewood Hospital. So I'd want to call on Sherry and ask her, do you have any other things you'd like to say about your patient, about the surgery and the outcome?
So thank you, Nathaniel. So obviously, so happy that it was a great outcome, and so happy for Kathy and all of the patients. And I guess I would say, in the general sense, we're old. I guess we've been around for a long time now as the program. We actually, I think May 1st was the 30-year anniversary of me starting in the position as wellness coordinator. So I really feel old, but it's not about that. It's that, I think in so many ways we have come so far. Most importantly, we've hopefully had the privilege of helping a population of patients that were underserved and disturbed and misserved for a very long time. And we continue that strong tradition. But again, many of the things that happened at Englewood gave birth to larger concepts because it made us rethink what we were doing with all the other patients that we were transfusing without a lot of good information, a lot of good evidence. I remember as it was Neil, I think you said a moment ago, I'm sorry, it was Neil or Bruce, talking about Paul Tarter's paper. I remember very, very early on in my very first days having just a tiny handful of papers from Dick Spence and a couple of others. And those who were working on implementing bloodless at Englewood Alfred said, please, 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 to you and all your colleagues, publish. So, I'm so appreciative that and so honored that we've had the privilege, most importantly, again, to touch patients, but also to embed this in a culture and have some of that, lots of that spread beyond, and hopefully inspire and hopefully energize not just people on this call, but beyond, so that really these scientific principles are applied to all patients and we see the progress. But, we still, as many have said on this call, we still have a ways to go. But it's personally rewarding, inspiring, and the hospital remains as committed as ever with all the changes, the crazy changes in U.S. healthcare, which we almost can't keep up with in this country. A subject for a different day, but I'm very proud that Englewood still continues that as an unbending part of their culture and their.
Sherry, can I ask you that? Can I ask you that about? Sherry, can I ask you that about as you and Aryeh left Englewood? How was the process in making sure that you said it's an unbending part of their culture? How was that process, and is it truly embedded in their culture? I'm sorry. Is it truly embedded in the culture of Englewood, and do have people followed in your footsteps the way you'd like them to?
Thank you, Bruce. And both Ari and I still have roles at the hospital. Certainly not in the same activity we were before, but we keep our ties closely with various levels of involvement in projects, etc. So, I think we're able to have a good eye on things, not in a Big Brother sense. But to answer your question, I think that, sort of taking that universal approach, if this is something that everybody needed to learn about on their way through the door, and it was just normal. It wasn't exceptional. It wasn't marginalized, and that's kind of from the early building days. The way that I tried to approach it was that, these patients are just like all other patients with the same needs and the same concerns and the same fears and the same hopes. So to make it all about whether or not they wanted a blood transfusion, we're focused completely on the wrong thing. Like, I think that was the message that we tried to embed early on. And what did that mean? It meant sort of a lot of manual education 30 years ago, going around and speaking to individuals and groups and everything else. But I think technology helped us. Technology is not the answer to everything, but embedding that with really good messaging, with really consistent, constantly updating messaging in the electronic medical records. As an example, when patients come to Englewood, many of you are, if you're US based, know Epic, right, is the dominant medical record. But as an example, on the patient portal of the Epic Medical, it's called My Chart, in the United States, but and Epic may be beyond the States now probably. But anyway, when patients answer the questions on their own patient-facing profile, I think it's the third question maybe that they're asked after their name and demographic is, how do you feel about blood transfusions? So, those kinds of things that just become in front of patient faces, every single patient is asked that, right? And some patients would probably say, well, I don't know why they're asking me that. But for patients for whom this is important, that's so rewarding. But for all patients, it raises it to the surface. And often prompts questions or conversations with their providers to say, why did they ask me this question? Why is this coming up? So that, and I think, introducing every group of nursing students. We have a nurse residency. All of those interns, right? In year one, we get them. We teach them to park, and then by August, we're embedding that in their experience, and that is actually, they see it as an asset when they leave the time at Englewood because they have a marketable skill to get a fellowship, etc. So I think it's just that that cultural embedding and keeping up with the science. This is bloodless medicine and surgery, inpatient blood management is not a marginalized accommodation. It's based on evidence-based care, right? If that's the model that we're in. And I talked a lot through some. I don't know if I answered your question, but I see your hand again. So.
No, and I don't want to usurp all the conversation if anybody else wants to join in, but it does strike me that Englewood is so successful at what they do, and they're right across the river from all these hospitals in New York City. It just amazed me always that the big hospital medical centers and the big medical schools in New York City aren't saying, let's wander across the Hudson River and emulate this community hospital that's changing the world. Earlier it was asked, how do we get the definition of blood as an organ? And to me, the way to do it is for us to start targeting deans of medical schools, and maybe even sponsoring 10 or 20 deans of medical schools to interact with SABM and BMSS to talk about teaching it in medical school instead of ignoring it, but have a 2-week lecture series on blood as an organ and the transfusion decision and the history of transfusion and all these problems. It's the most widely used therapy, and it's got horrible outcomes that people need to know about.
And we hope that no one document is going to solve this, right? So, and I know I wasn't here for the whole conference. I'm sure people refer to the World Health Organization document, which probably has a lot less traction in the United States, perhaps in other countries. But included in that model is what is the responsibility of medical schools, nursing schools, of other professional education, along with professional societies, Now, I don't think every country is going to immediately pick that up and run with it. But there are some countries that at the national level, I and others have had the opportunity and the privilege of interacting here in Belgrade, Serbia, interacting with the national health systems, and emphasizing where this fits in recognizable health prevention model, right? This again is not something on the fringes or not something just to be addressed by transfusion services. Talking about the overall health of your population, this fits right in with that, right? And I think we've talked about this in such a segmented fashion that it's for one particular group of patients or it's about the blood supply. It's really not. Bloodless surgery and patient blood management. Really, if you look at, and you had that article, maybe some got to read it, Dr. Shander, and a couple others worked on that I was able to work on, but putting it in that, primary, secondary, tertiary, quaternary prevention model, PBM fits right in with that, but we haven't put it in that model. We're still describing it as something sort of out there a little bit. And I think as we, incorporate it more the way we do heart health and other elements of things that we talk just as much about prevention as we do about intervention. I hope we get there with deans of medical schools and everyone else. And I hope each one of these steps, like the WHO document, they're another climb up that hill, but it's still a big hill to climb, I think.
Yeah, it was interesting that they brought up that Dr. Lappin used, rare blood and blood shortage as sort of his way that he was able to provide surgery for that patient, because sometimes it's a way, that I also justify not transfusing a patient. Say they order 2 units of red cells and I say, well, we're running a blood shortage here, and you have to really be judicious to try to cut them down. So it's kind of a an interesting strategy.
I think so.
Mark,
Again, I'm sorry, Bruce. I didn't mean to interrupt you.
I was just gonna say, Mark's been such a leader in this, and I think that's a great way to think, Mark, is for you to ask anybody who's coming in to work with you to say, what would it mean to the blood shortage if we saved 2 units today? If everybody thought that way, 1 or 2 units, we'd have a whole lot less blood shortage, and say, do we really need to do that? What are we treating?
I think we're making a lot of progress because we have strong voices like Dr. Friedman here and Dr. Blomberg. They are all members of the Bloodless Medicine and Surgery Society, just like you, Dr. Spies, and Sherry. So I think we're poised to make a lot of impact on the medical world to try and steer everyone in the right direction. And so our patients, it's their chance now to tell us about how good or how bad bloodless care is. So Sherry, I'll hand over to you, please.
Okay, so we have with us Samuel, who's gonna share his experience now. Am I correct?
No, Samuel is the doctor.
Yes, I'm sorry.
Marcus that is going to share.
Marcus. Sorry.
So, okay, so.
There's Marcus, sorry.
Yeah, he's right here with us. Please, Marcus, could you unmute yourself? And Sherry wants you to tell us what bloodless surgery you had, when it was, and why it was necessary for you to have surgery. Are you able to unmute? Let me see if I can help him with that.
Here he goes. He's coming. He just was frozen up there for a little bit.
All right. What I was trying to say, I fell in 2018 and sustained a fracture of a neck of my right hip bone. I could not walk. So I had to have the replacement of the throat surgery. That was what happened at that moment. Then the other question.
Yeah, so yes, the other question about what did you choose to have bloodless surgery? Is that what you want to talk about?
Yes, that's what I wanted to say. For an answer to that question, if it was my choice, not any other person, it was
And
my
why?
choice to, hello?
Why did you choose bloodless surgery?
All right. I choose bloodless surgery because after knowing that my back cell volume was only 15%, I was so worried. I couldn't walk. So I looked for an expert who can give me or handle the surgery without violating God's law, stated in Genesis chapter 9, verse 4b, Leviticus chapter 7, verse 26, and Acts of the Apostle, chapter 15, verse 29. As a Jehovah's Witness, I adhere strictly to this law. So I had to make sure bloodless surgery is done.
So this had to do with your religious belief and
Yeah.
protected in medical science by patient autonomy and the ethics. So tell us how you went about seeking for and obtaining the bloodless care.
In fact, I went to Dr. Nathaniel, a bloodless surgeon, for proper advice on my low back cell volume, the PCV. He advised me to optimize my blood. He administered 8 bottles of intravenous iron and erythropoietin over a period. After that, the back cell volume was raised to 38. You can imagine from 15 to 38. And immediately after that, Dr. Samuel Urum, an orthopedic surgeon, decided to take up the surgery without the use of donor blood. I also complied with the doctor's directive in taking the drug for optimization. So that was my own area of struggling to get the bloodless surgery done.
All right, you've answered part of the next question, which was what steps did the doctors take to ensure that the surgery was successful? Are there any other steps that you know about that they took?
Yes, there was. They supervised my optimization and saw that my back cell volume had risen for a successful bloodless surgery. They involved the hematologist and the anesthesiologist in planning the surgery. And they administered some medications during surgery to minimize blood loss, which was the concern of a doctor.
Absolutely, because bloodless surgery is not a one-man show. It is a multidisciplinary endeavor. So it was proper that others should be involved, not just your surgeon. So how did the surgery go and what was the outcome?
It was successful because the doctors were very, very serious over me. The outcome was full of joy, quick recovery, and no complication. I was home on crutches within 14 days, and later I started bearing weights. I remained in good health till 7 years later. That is like today I'm talking here. 7 years now. No problem with me.
That is wonderful, Marcus. So, do you have any regrets? I think we have the answer to that, but we still want to hear from you. Do you have any regrets for choosing bloodless surgery? Or
Not at all. Not at all. Because bloodless surgery was very, very useful, and it's still useful. No regret at all. There were many benefits, like the system, the process is very cheap. It brings quick recovery, no risk to hazard of blood transfusion. Also, I had a clean conscience toward my God, Jehovah. Of course, I told you that I am a Jehovah's Witness. So I had a very good conscience with him.
Thank you, Mr. Ian. Any final thoughts you would like to share with the audience?
Yes, I have so many, but I just want, because of time, I just want to tell them very little. In that case, I want to advise, if any need for surgery, please, it is better to look for bloodless surgery first. No other alternative.
That's a powerful recommendation, Mr. Thank you so much. Sherry, do you have any questions for Mr. Ian's doctor, Dr. Samuel Uro?
Yeah, Dr. Samuel.
No, okay, you want to say something to him, you can, but I was asking Sherry if she had questions.
Okay.
Dr.
Yes.
No, I guess an overall comment of, how did you approach this from a philosophical perspective? As a physician, that this is not how maybe your training was to take care of a patient like Marcus, and how do we help others to have the open mind to do this universally?
Before you answer Sherry's question, Dr. Ro, I want you to fill us in if there are some things that you want to fill us in on about your patient, what was wrong with him and the surgery you did.
Greetings all. Thank you very much for this opportunity that you've given me to share my little experience. Yes, the patient that has just spoken, Mr. Marcus, presented with a femoral neck fracture from a domestic accident. So when he now told me about his faith, it was a challenge to me. And medical practice is faced with challenges, and we have to face these challenges whenever they come. And therefore, I took it as a challenge to do a hip surgery without blood transfusion. I took it as a challenge. So first and foremost, I had to investigate him, do a full blood count, and to my surprise, his packed cell volume was just about 25%. And the HB was about 8.6 grams per dl. So I delayed the surgery and did some more optimization of the patient, optimizing him with erythropoietin injection. He had 6 doses from me and oral iron preparations. And after about 3 weeks or thereabout, the packed cell volume appreciated dramatically. It appreciated. I also advised him on dietary intake. So the packed cell volume rose to about 42 and a fraction. I can't recall the exact fraction. So we were set to do the surgery. And we also tried to prevent unnecessary bleeding within the clotting profile of the patient, which were within normal ranges. So we had other things ready, like the diatemy, surgical diatemy, and then we also had plasma expanders, all in case of any eventuality. So we embarked on the surgery, which went on very well. Within the time, no much bleeding, and everything went well. So thereafter, post-op, it was not turbulent, bearing weight. We purposely delayed this weight bearing so as to avert any infection that may also jeopardize our surgery. So the post-op was okay. He started bearing weight using the Zimmer working frame on the working frame. And after the second week, 14 days, stitches were removed, wound was dry, and everything was okay. So we now asked him to use a walking cane for ambulation. And after some time, I had seen him walk without a walking cane, which he told me that he does his ambulation without a walking cane, and he drives his car. So that is just about the patient.
I want to corroborate what you said. He actually forgot his walking cane in my office.
Okay, yes. And subsequently, I have developed a tough skin doing orthopedic surgeries, bloodless. Thereafter, I had a patient, a young man with a tumor on the distal femur, a member of the Jehovah's Witness, and he came with a PCV of 15, hemoglobin of roughly about 5. And we need to take away, we counsel him for an above knee removal of the limb. It was quite a massive tumor. The whole bone, distal femur, was destroyed. So I contacted colleagues in the hematology department who gave me aid. They now came up with erythropoietin and advice to the patient on what to do. And we went into the surgery using an above knee tourniquet, high up tourniquet, taking care of hemostasis. And we did the surgery, and the young man came out good. The last was just about 5-6 days ago. A young girl of about 15 years old had bilateral tibial injury, tibial fractures for about 4 months now. So we look at it, non-union, and we had to go in. In her own case, the packed cell volume was about 38. So we did one after the other on the same sitting. That is, after one side, we removed the tourniquet and apply on the other side, and did. And she is quite free. So is something that we should sell to other surgeons and we should practice. So that's my thought about it.
Thank you so much, Dr. Rowe. So again, we may not have, we probably already have the answer to the question. Do you have any regrets for carrying out bloodless surgery on this patient? Or were there any benefits?
I will I have regret when I had a successful surgeries? What will I be regretting?
That's
So
wonderful.
I don't have any regret. I don't have any regret.
And there is something you said that you invited the hematologists.
Yes.
So that you got them involved. Again, that emphasizes the importance of a multidisciplinary approach.
Exactly. Exactly.
So when we started in those days when Mr. Young had his surgery, I was the one doing the IV iron and all that.
Exactly. That's true.
But at this point, our hematology department is expert in IV iron administration. I have not been called to give anyone IV iron for some years.
One of our colleagues, Dr. Marcus Iyama, is quite handy. He is ready at any time to give assistance when called upon. So, and that is why you have not been having calls from us.
Okay, that's quite commendable. Any final thoughts you'd like to share with the audience, including the answer to Sherry's question? I think she was asking about how you're going to make it, make a wider application.
Yes, what I would say there is, bloodless surgery is something that we all can take part in, and it's easier, like Mr. Yama has just said, it's easier, but precaution is very important. Patient selection is very important. Patient preparation is also very important. So when we take all this into consideration, you will see that bloodless surgery is are procedures that can be carried out even when one may think that they are risk. One will just go through without any risk.
Thank you so much, Dr. Rowe. Sherry, are you still there, Sherry? Because I wanted to turn it over to Sherry, but as you heard from Sherry, she is somewhere in, I think it's Eastern Europe right now, in Serbia. That's where she is. She moves all over the world, trying to get clinicians to move away from blood transfusion to bloodless. So please do excuse her if she has to attend to something at the moment.
All right. Yeah. Thank you.
So I will just step into her very big shoes to thank everyone here, from Kathy, Arturo, and of course Sherry. So if any of you has any final thing they want to say, share with anybody, Marcus, Kathy, you are free to say before we sign out.
I just wanted to say thank you for this opportunity. I think this is wonderful what you guys are doing, informing people of bloodless surgery, the benefits, and in fact, the only way to really go, for better health. So thank you again for allowing me to be a part of this.
Thank you, Kathy. Greatly appreciate your being here. Marcus, you want to say something? Mr. Yang? You need to unmute yourself first, please. If you just touch the screen first, touch the screen and the microphone. Oh, we are losing what he's saying. 1 second.
So should I unmute again? Okay. So what I wanted to say is that bloodless surgery is the best. And the doctors involved in bloodless surgery, everybody involved in bloodless surgery should cooperate with the system and be more serious to help those who are sick toward bloodless surgery because it is very cheap, no complication, nothing for trouble. So let them continue to watch over bloodless surgery so that they can continue to help others. Thank you very much.
Thank you, Mr. Yang. Dr. Rom?
Well, I thank you for the opportunity that you've given me to share my experience. As I had said before, something quite and we will now be thinking of complications of allogenic transfusion of blood. So I want to thank you very much for this opportunity. Thank you.
Okay, thank you, everyone. On behalf of Sherry and myself, I want to thank all the participants in the panel discussion, which was on patient's blood, the best blood, which is a theme of the World Bloodless Surgery Day 2025. So with that, I hand over back to Dr. Spies and Adrian.
Okay, so thank you for that panel. That was very interesting and nice to hear people's real life stories with experiencing bloodless care surgeries and how successful it can be. So for a preview for tomorrow is our last day of Bloodless Medicine and Surgery Week. There will be a talk on erythropoiesis stimulating agents and how they're a powerful weapon with orthopedic bloodless surgeries. And then they'll be ending the day with a bloodless medicine and surgery basic quiz. And that will be the end of our exciting week that we've been able to enjoy. And before we close for the day, just if our panelists can turn their cameras on for a brief photo, and then we will be able to end the talk for today.
Yeah, so Adrian wants all of us to turn on our cameras, and then I think we're going to be all spotlighted. All of us have to be added to the spotlight, rather, so that we take a picture. Sorry. Schneider, please, could you help us here to add everyone to spotlight? Not to forget Schneider himself. Is everybody in? I can't see Dr. Spies. Is he gone?
Yes.
Okay.
Yes, he's gone.
Oh, I see. Okay. All right. So anyone else who wants to turn on their camera? Otherwise, please, Schneider, please, could you take us a picture? But first, tell us when to smile. Should we smile now? Because I don't smile all the time. Uh, everybody can do a screenshot, please. And when we are done, please let us know. Schneider, if you're saying something, we cannot hear you.
Okay, I said, does anybody have their camera on that do not see themselves on the screen?
I think Dr. Rome is not here. Let's add him. Or
Dr. Room? Okay.
oh, he's been added. He's been added, but somehow, okay, maybe my
He's there, but he's not showing.
he's not showing, yeah.
Okay.
That's strange.
So I'll go ahead and grab a shot. And everybody smile now.
Okay.
Smile, hold it.
Abigail is not smiling.
I mean, that's by my picture, but
All right. Let me see. All right, I got it.
Okay.
I think we're all good.
Oh, great. So we can replace everybody with Adrian.
Okay, so with that, I think we can adjourn today's meeting and we'll see everybody tomorrow for our final day. Thank you so much for joining us today. And once again, to our speakers, they were wonderful.
Thank you so much. Thank you, Adrian.
everyone.
And
Thank you.
Peace and the speakers.
Night, I will see you tomorrow.
Yes, I'll see you tomorrow. Bye.
Yeah.
All right, I'll go ahead and
Yeah.